My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And our Learn and Share conference call this evening, the first one of the year, is on Pediatric Epilepsy Surgery Evaluation. And we're very happy to have with us Dr. Eishi Asano and Dr. Aimee Luat from Children's Hospital of Michigan, both pediatric epileptologists there. So welcome, and can each of you just start by giving us a brief summary of your clinical and research interests and also your experience with this topic?
So I can go ahead. I'm Aimee F. Luat. I'm a pediatric neurologist and epileptologist at Children's Hospital of Michigan in Detroit. So I have a special interest in pediatric epilepsy. I underwent pediatric neurology residency and epilepsy fellowship in DMC as well. I am board certified in pediatric neurology, neurophysiology, and epilepsy. With regards to research, I have research interest in clinical epilepsy, those children with difficult control seizures. I also have special interest in tuberous sclerosis, which is a genetic condition associated with epilepsy.
Great. And Dr. Asano?
Yeah, hello, I am Dr. Eishi Asano, Professor of Pediatrics and Neurology in Wayne State University and the Medical Director of Neurodiagnostic of Children's Hospital of Michigan. When I graduated from medical school about 20 years ago, I became a neurosurgeon, but after finishing my residency of neurosurgery in Japan, I decided to come over to United States, and I decided to become neurologist. Now I am functioning as a neurologist, and my research interest is human brain mapping. The goal of epilepsy surgery is to eliminate seizures, but I want to improve the quality of life after the surgery. So my human brain mapping is supposed to improve the quality of life to diminish the risk of epilepsy surgery.
Great, great. And we'll talk more about that today. And I should say that, even though you're both pediatric epileptologists, I think we do have some adults on the line and I think a lot of what we'll be covering will be very relevant to adults as well. So let's talk about epilepsy surgery. It's often seen by families as a last resort, and you can certainly understand why people might have that view and why they might be reluctant to consider surgery. However, there are a number of reasons why surgery should be considered much earlier in the process than it often is. Can you talk about the various benefits of being evaluated for surgery sooner rather than later, and again, why it's important to do that early in the process?
Yeah, especially for children, early surgery, if the patient has uncontrolled seizure and there is a seizure focus, early surgery improves the quality of life and cognitive and developmental outcome, and also this would allow the child to lead a normal life. That's why we encourage if a child has intractable epilepsy, which we define as seizure that is not responding to at least 2 or more seizure medication, that they should be seen in a level 4 epilepsy center to be evaluated for surgery. Because if they are a surgical candidate, that will greatly improve their quality of life and developmental outcome, and also because of the, children's brain has this element of brain plasticity. So the sooner the surgery is done, the better for the brain to recover. In addition, each seizure, especially if it is uncontrolled, is associated with status epilepticus, and mortality rate is also higher in those children with uncontrolled seizures. So that's why we encourage any patient, adult, or child, if they have uncontrolled seizure, that they should be evaluated for the possibility of epilepsy surgery.
Right. Dr. Asano, do you have anything to add to that?
About the brain plasticity, why do we have to do a surgery earlier? Because, brain plasticity is maximized around the age of between 2 and 6 years of age. At that time, the number of synapses grows. Afterwards, gradually the number of synapse means synapse is something connect between the neurons. The brain synapse gradually go down throughout the adulthood. And then around the age of 12 or 16, the number of synapses is about same as adult. So therefore, it's recommended that surgery should be done before the puberty. But not necessary. But if you do a surgery before the puberty, then chance of recovery from surgical damage is much better. So we strongly recommend earlier surgery.
Right. So, in general, what are the circumstances under which patients should be evaluated for epilepsy surgery? Obviously, epilepsy surgery isn't for everyone, but what are the key factors that would indicate someone should be evaluated?
Yeah. So epilepsy surgery should be considered if a child is not responding to at least 2 appropriate anti-epileptic medication. When you say appropriate, that means the seizure medication is the right type of medication for that child, and that child is already on 2 of these medications or more and is still having frequent seizures. That's the time that we should refer the child to a level 4 epilepsy center for possible surgical evaluation. In addition, there are certain epilepsy syndromes that tend to be catastrophic. Like, for example, there are congenital brain malformation like hemimegalencephaly, wherein the child would have frequent seizures, and we know that this kind of condition can be responsive to surgical treatment. That's another reason or another type of patient that should be referred to us to an epilepsy surgery center for evaluation.
Okay.
Do you have any addition, Dr. Asano?
Yeah. In patients who have malignant tissues, malignant doesn't mean cancer, malignant tissues, removal of such tissues can result in the better developmental curve. Patients with epilepsy may have smaller slope of developmental curve, but the epilepsy surgery can lift up the slope of development after the surgery. So therefore, if your child has medically uncontrolled seizures, it would be nicer to consider the removal of such malignant tissues responsible for seizures.
So, for the purposes of today's call, we'll focus primarily on resective surgery, which is the most common type of epilepsy surgery performed. But can you briefly review the other types of surgery, and what they accomplish and when they might be considered?
Okay. So resective surgery is the most common procedure, which is defined as removal of seizure focus while preserving the functionally important cortex. That's the resective surgery. The goal of epilepsy surgery is eliminate seizures with minimal side effects. That's the goal of resective surgery. But there are several other epilepsy surgeries. Let's talk about such other surgeries one by one. The first other type of surgery is corpus callosotomy. Corpus callosotomy is often employed to patients who have bilateral seizure foci. If seizure focus is located in both left and right hemispheres, we cannot remove both hemispheres because that will result in the catastrophic cognitive impairment. So therefore, we can offer another type of surgery, which is a corpus callosotomy, defined as dissection or disconnection between left and right hemispheres. Thereby, we can expect reduced severity of seizures, particularly seizures resulting falling. Falling seizures will falling seizures typically respond to this corpus callosotomy very well. And Dr. Luat has recently summarized the results. Dr. Luat, can you tell us how often corpus callosotomy eliminates falling seizures?
Yeah, basically we recently submitted a paper on this topic, the outcome of corpus callosotomy among our patients with intractable epilepsy and uncontrolled seizures. So we have a total of 20 plus patients, and approximately 85% of them showed a 50% reduction in seizure frequency, which is a good outcome because, usually these children have debilitating and life-threatening falls because, whenever they have big seizures like that, it will cause them to drop to the ground. They may injure themselves. And in our series of patients, more than 70% of them had more than 50% seizure reduction, and about 30% become free of this type of seizure. So it is a type of procedure that tends to help many of these children who had intractable drop seizures.
And corpus callosotomy is considered largely a palliative surgery, right? Where
Correct.
It's rare that people become completely seizure-free, but many become free of the drop seizures and then or at least significantly reduced drop seizures.
That is correct.
Right.
That's correct.
Right.
And then, good point. Point of the corpus callosotomy is improvement of the quality of life of patients as well as caregivers, right. Because patients with frequent falling seizures need a constant observation by the parents. But we can reduce such effort of parents by reducing or even eliminating the falling seizures. And our hospital has an outstanding surgeon, Dr. Sood. Dr. Sandeep Sood can perform this corpus callosotomy using endoscope approach. So therefore, he can perform the corpus callosotomy with only 1 inch of skin incision and the keyhole craniotomy. So therefore, patient can be discharged sometimes 1 or 2 days after the surgery.
Okay, great. And other types of surgery that are less common than resective surgery?
Mm-hmm. Yeah, less common resective surgery includes hemispherectomy. Some of the children may have massive seizure focus involving one hemisphere. Such patients may have 100 seizures or even 200 seizures a day, and typically they show the significant developmental regression. Patients may lose the language. Patients may lose the attention to the parents. In such cases, we can offer endoscopic hemispherectomy, which means disconnection of seizure focus entirely from the one hemisphere. Such patients typically already have weakness on one side, either left-sided weakness or right-sided weakness. In that case, hemispherectomy does not add much of the cognitive dysfunction or motor dysfunction. Nonetheless, the chance of seizure freedom is up to 90%, which has been recently submitted to a journal. So in case your child has very frequent seizures associated with massive epileptic focus in one hemisphere, we can offer endoscopic hemispherectomy, and then motor symptoms won't be worsened in case your child has already weakness. But if your child does not have weakness on one side, then hemispherectomy may not be recommended because such hemispherectomy will result in the severe weakness. Right. So in that case, we can offer subtotal hemispherectomy. We can remove the entire hemisphere except for the motor cortex. In that case, chance of seizure freedom is about 70%, not 90%.
Okay, great. And what about multiple subtile transection? Is that used much anymore?
Oh, no, we still use multiple subtile transections. You know, when you perform the resective surgery, removal of the seizure cortex, sometimes seizure cortex is involved the language cortex or motor cortex. In that case, rather than removing the seizure focus, we can make a slit, like a slit on the cortex every 5 millimeters, and we can disconnect the connectivity network between seizure neurons by making a slit. If you perform the multiple subtile transections, this is, again, palliative surgery, so therefore we cannot offer you the chance, like seizure freedom chance of 80%. We can't say 80%. The chance of seizure freedom is between 50 to 80% if you perform the multiple subtile transections. But the benefit of multiple subtile transection is reduced risk of permanent deficit. If you remove the hand motor area, your child is going to have permanent weakness of the hand. So if this deficit is not tolerable, we can offer multiple subtile transections. Thereby, chance of seizure freedom is between 50 to 80%, but the risk of permanent deficit is low.
Okay, and you said that's often combined with resective surgery?
Correct.
Okay.
Correct. We can combine the resective surgery and the multiple subtile transection together. Correct.
Okay. And lastly, what about laser ablation surgery?
Yeah, laser ablation has been recently proposed by a number of institutions across the United States as well as the world. The laser ablation, the benefit of laser ablation is the craniotomy is very small, so they can perform the ablation through the burr hole, like a keyhole craniotomy, and thereby. So the incision is so small, so therefore they can be discharged next day or 2 days after the surgery. So that's the benefit of laser ablation. It's particularly useful for patients who have seizure focus in a deep location. They can ablate seizure focus by laser efficiently. But the outcome of laser ablation is not still optimal. If you do the resective surgery, we can offer the seizure freedom of chance about 80% chance of seizure freedom. But the laser ablation, the outcome has been, variable outcome has been reported. Some institutions report only 30% of patients became free from seizures. Other institutions may have reported a better outcome, but at this moment, the outcome chance of seizure freedom is considered to be smaller on laser ablation compared to resective surgery.
Okay, great. So if a family decides that they'd like to go ahead with pediatric epilepsy surgery evaluation, what are the basic steps involved? What's the flow chart that you go through in helping them with that decision?
Yep. Correct. The first step is to do a video EEG monitoring, simultaneous recording of video and EEG, typically 1 to 3 days. Why do we have to do it? First of all, we have to rule out non-epileptic events, because not every shaking episode or not every staring episodes are seizures. So therefore, we have to rule out the possibility of non-epileptic events. Up to 30% of patients who are believed to have seizures indeed had non-epileptic events. Some of them may have been associated with psychological stress rather than brain disorder. If psychological stress induces seizure-like episodes, we don't recommend epilepsy surgery, or even we don't recommend epileptic medications. So therefore, first step in the treatment of epilepsy is video EEG monitoring and rule out the possibility of non-epileptic events. Once we found that each patient, given patient has epileptic seizures, we do localize the seizure focus by doing video EEG monitoring, which lasts about 1 to 3 days typically, and we will determine the generous localization of seizure focus. Second step is imaging. Imaging includes MRI, brain MRI, as well as brain PET scan. Brain MRI can determine the location of abnormal brain structure. PET scan it stands for positron emission tomography. PET scan determines the functional integrity of the brain. Seizure focus tends to be lazy. So therefore, seizure focus does not use the glucose compared to other healthy brain regions. So both MRI and PET scan are useful to delineate the margin of seizure focus. The last important test is neuropsychological testing. We want to assess the impairment of language or spatial skills because patients with seizure focus on the left hemisphere tend to have impairment in verbal testing. On the other hand, patients with seizure focus in the right hemisphere tend to have a problem in the visual spatial processing. So neuropsychological assessments are also useful to determine the seizure focus localization. Dr. Luat, anything to add?
I think Dr. Asano has summarized the pre-surgical evaluation test that we do in Children's Hospital and in other level for epilepsy centers. We can discuss details about the video EEG if you want.
Right. So we can go into a little more detail on these a little bit later. But after that initial round of the video EEG monitoring, MRI, PET scans, and neuropsychological testing, if someone is found to be, based on that, a surgical candidate, what additional tests may be done beyond that to further localize where the seizures might be coming from?
Well, first, go ahead, Eishi.
Go ahead, Dr.
We have done these testings. We typically discuss the child's case in our epilepsy conference, which we hold every Monday, every week, where we discuss 2 or 3 cases of intractable or medically uncontrolled seizures. We present the data to our group. If there are any concerns about the localization or lateralization of where the seizure focus is coming from that we were not able to figure out with the basic testings that we do, that's the time that we proceed with other testing.
Okay.
So, as I told you, like video EEG monitoring, imaging, and the neuropsychological testing, those 3 tests can localize seizure focus in about 90% of surgical candidates. But in the remaining 10% of patients, optional tests can be considered. optional tests include, for example, magnetoencephalography, which is offered by Henry Ford Hospital. Magnetoencephalography can measure the magnetic discharges instead of electrical discharges. This test is supposed to be useful to detect the seizure focus from deep focus. So this is one option. The advantage is, detection of the seizure focus from a deep focus, but the disadvantage is this is a rather expensive study. So therefore, you may want to make sure that your insurance company cover the cost of magnetoencephalography.
Right.
Another modality is functional MRI. Functional MRI is another type of imaging which can measure the blood flow changes during the test, during the language, or during the memory. By doing this, you can generously localize the location of language cortex. So therefore, you can determine the relative spatial localization between language area and the seizure focus. So therefore, we can give the estimate of language decline following the surgery. If functional MRI and suggests language cortex is close to the seizure focus, we have to do more precise language mapping, which is covered by, which is done during the phase 2 evaluations. Do you want to cover the phase 2 evaluation?
Sure. Yeah. Let's
right.
go on to that, where you're getting even more detailed information on the seizure focus.
No problem. So magnetoencephalography or functional MRI, so they are all non-invasive studies. But and if your child has seizure focus and which is far away from the language cortex or motor cortex, we don't have to do another test. We can simply go to the operation room and remove the seizure focus without being worried about the language or motor deficit after the surgery. But in case language cortex and the seizure focus are expected to be close, we often offer two-stage surgery. Two-stage surgery means we perform the phase 2 evaluation by placing subdural intracranial electrodes on the brain surface. So each patient will have two surgeries. First surgery is placement of the electrodes on the surface of the brain, and afterwards, a surgeon closes the brain, and the patient will be transferred to the inpatient ward. Then we perform several types of brain mapping, either using electrical stimulation or new type of functional brain mapping, which is referred to as four-dimensional brain mapping, developed by our group. So thereby, patient will communicate with computer. And during the communications, we analyze the EEG changes, then determine the exact location of language cortex. So after doing such two-stage surgery, we will remove seizure focus, but preserving the language area. By doing this process, then we can offer the patient the good chance of seizure freedom with minimize the risk of language deficit.
Great. And can you talk about the difference between actually placing grids or depth electrodes on or in the brain versus SEEG and the availability of that as well in Michigan?
Yep. Grid EEG means that's a plate electrodes. plate electrode is placed, like grit EEG is a kind of plate electrode, which is placed on the superficially. So this is useful to determine the margin between seizure focus and the functionally important area, such as language or motor area. And SEEG is a rather new technique, which is a EEG recording from the depth electrode. So depth electrodes are placed inside the brain, and then we can detect the seizure activity coming from the deep focus. So SEEG is useful in case seizure focus is estimated to be localized in deep area. Otherwise, grit electrodes are better suited for children because children tend to have larger seizure focus, and the seizure focus could be close to motor or language cortex. In that case, grit electrodes can better define the margin between seizure focus and functionally important area.
Okay. So a couple other things other tests that may be used. The ictal SPECT. Can you talk a little bit about that and the circumstances under which what that involves and
yeah.
when that might be used?
Yeah, ictal SPECT is also a non-invasive study, and then this will involve the two blood flow scan. As I told you before, seizure focus is generally lazy. Seizure focus tends to use smaller amount of energy and blood flow. So if you inject like a radio tracer during like in between seizures, seizure focus is appears cold because they don't use the energy or they don't use the blood flow. But during in the second SPECT scan, we intentionally inject the radio tracer during seizures. Seizure focus tends to use much more greater energy during seizures. So if you inject the radio tracer during seizure events, seizure focus is supposed to light up during the seizures, during the second SPECT scan. So ictal SPECT can be useful to localize seizure focus in case your child has long-lasting seizures. But if your child has short-lasting seizures such as 5 seconds or 10 seconds, ictal SPECT may not be useful. Another disadvantage of ictal SPECT is some of the patients may have seizures only during the night time. In that case, ictal SPECT may not be feasible because radio tracer is available only during the daytime.
Right. Okay. And what about the WADA test?
WADA test is a somewhat invasive test because we have to put the catheter from the femoral artery from the leg. This WADA test is useful to localize lateralize the language cortex as well as memory cortex. By putting a catheter from the femoral artery, and we can anesthetize one hemisphere each time by giving some anesthetic agent. So in one time, we can make the right hemisphere sleep and the left hemisphere awake. If right hemisphere is asleep, patient can speak. This means that left hemisphere is giving the language process. So that means left hemisphere is language dominant. If left hemisphere is anesthetized and the patient lose the speech function, then we can again consider that left hemisphere is language dominant. Same thing can be done for the memory. But because WADA test is now considered as somewhat invasive, and there is a risk of complication up to 3%. So therefore, particularly in Europe group, WADA test has been pretty much abandoned because functional MRI and PET scan, MRI, such imaging tests can already sufficiently estimate the language dominant hemispheres. So therefore, now the role of WADA test has been reduced. In pediatric epilepsy program in our children, we have not done WADA test for the past 3 years because other modalities already could localize the language cortex in a sufficient manner.
Okay, and is this a fairly recent change? I mean, like if you look 10 years ago, were WADA tests pretty much performed in most surgeries?
Yes.
Or? Okay, interesting.
Yeah, WADA test was common in 10 years ago, but for the past 3 years, we haven't done WADA test because other modalities could localize language as well as memory area.
And Eishi, during your second stage surgery, you can also do the what we call
Correct.
electrical WADA test.
Yes, I mean during the phase 2 evaluations, we can stimulate the language area as well as memory area in a pinpoint manner. So accuracy of language and the memory mapping during the phase 2 evaluation is much more accurate compared to the WADA test. So therefore, there is no reason to do WADA test for our patients.
Okay, and again, roughly what percentage of patients end up having to have phase 2 done, and what percentage are you able to do the surgery without having to do that process?
About 50% of patients have seizure focus away from the functionally important area. In that case, about 50% of patients go to the one-time surgery.
Okay.
On the other hand, the remaining 50% of patients, the distinction between seizure focus and the functionally important area may not be sufficiently clear. So about 50% of patients, we recommend phase 2 evaluation. Then we can offer much more safer surgery.
Okay, great. So obviously, patients and families should seek epilepsy surgery evaluation at a level 4 comprehensive epilepsy center. Unfortunately, Michigan has 7 comprehensive epilepsy centers, and there are several others in bordering states as well. So when selecting which center, which epileptologist, and which neurosurgeon you use, how important is it to have access to all of the technologies that we just discussed? Yeah, go ahead.
Yeah. First of all, insurance. If insurance company does not support the surgery in out of state, we wouldn't recommend the patient going out of state because we have a level 4 epilepsy center in Michigan, particularly Children's Hospital of Michigan, as well as another also has another Children's Hospital of Michigan, another Children's Hospital. So, because of the insurance coverage, we recommend you to stay in the Michigan. That's number one. Number two, okay, again, we have a number of pre-surgical evaluation modalities, but not every patient needs all of the modalities. Right. Again, as I told you, if you have video EEG monitoring, MRI, PET scan, neuropsychological testing, more than 90% of the patients, we can sufficiently localize, or we can generously localize the epileptogenic zone. And the phase 2 evaluation can determine the exact margin of the seizure focus and the functionally important area. So therefore, you don't have to necessarily seek for every diagnostic modality to optimize the surgical outcome. So the important one is, first, video imaging monitoring, MRI, PET scan, and the neuropsychological testing. Other modality would be considered as optional.
Okay. And how important is experience, like the number of surgeries performed at the epilepsy center or by that particular neurosurgeon?
Yes. Again, you want to know how many surgeries have been done by a particular neurosurgeon. If you Google, you will find the name of a neurosurgeon. If you find that, for example, my surgeon's name is Sandeep Sood, S-A-N-D-E-E-P-S-O-O-D. So if you put this Sandeep Sood on the PubMed, this is an important website, okay? P-U-B-M-E-D. If you put the surgeon's name on the PubMed, you will find the paper published by a given neurosurgeon. For example, you will find that Dr. Sandeep Sood has done more than 100. Actually, he did more than 500 surgeries, but there will be a number of case series studies performed by Dr. Sandeep Sood. So my recommendation is check the skill of neurosurgeon by using PubMed, PUBMED.org.
Yeah, actually, it's .gov. It's .gov instead
.gov, I'm sorry.
Yep.
.gov, yes. I'm sorry, .gov. So then you will find that, how many surgeries, how many hemispherectomies have been done by Dr. Sood, or how many surgery done by a particular doctor. PubMed.gov.
Experience is important, Eishi.
Yes. Even if
experience in doing those surgical techniques.
Yes. For example, this is epilepsy surgery is team surgery. Even if diagnosis is perfect, if surgeon is not optimal, we cannot get the optimal surgical outcome. And on the other hand, even if surgeon has outstanding skill, if diagnosis is wrong, you may end up with removal of wrong place. So therefore, you need to have good neurosurgeon as well as good neurologist. How to define the good neurologist or neurosurgeon? Go to PubMed, PubMed.gov. Then you will find the good neurosurgeon and the good neurologist.
Okay. And then also, do different epilepsy centers track surgical outcomes at that center?
Yes.
And by a particular neurosurgeon,
yes.
So you can see actual internal or get internal stats on what percentage are
yes.
seizure-free, the frequency of complications, and things like that. And can patients and families request that from the epileptologist?
Yes.
Okay.
Yeah. Okay. In general, our institutions have this much of statistics internally. About 70% of patients. We have done 500 epilepsy surgery since I became attending, director of neurodiagnostic department. Since then, about more than 500 epilepsy surgery has been done, and 70% of patients obtained Engel Class 1 outcome. Class 1 outcome means seizure freedom from the disabling seizures. And then 10% of patients had rare seizures following surgery. Rare seizure means up to 3 seizures per year. And 10% of patients had more than 90% of reduction of seizure frequency. The last 10% of patients had less than 90% of seizure reduction, which means failure. We don't consider that 50% reduction of seizure is success. We can state that 10% of patients unfortunately had a failure, which means less than 90% of seizure reduction. So that's the seizure outcome, and the seizure outcome varies across the surgical procedures. For example, if you do the temporal lobectomy or hemispherectomy, chance of seizure freedom is more than 80%. On the other hand, if seizure focus is close to the motor cortex or close to the language cortex, and if you perform the multiple subtile transections, not removal, then chance of seizure freedom will be much lower than 80%. So, chance of seizure freedom is kind of specific to a given patient. So you need to ask the doctor about your child's chance of seizure freedom, specifically.
Right.
And then in general, complication rate range from much more than 1%, but less than 10%. So that means if you do 100 surgery, at least one patient will have unexpected complications, but less than 10%, less than 10 patients would have such complications. Complication may include infection or unexpected weakness or unexpected language deficit. But such risk range between 1 to 10%, which is not negligible, but it's not high. And I have to be honest that because we have had 500 cases, and then one patient unfortunately passed away 3 days after the surgery because of the infection. That patient was somehow on the herbal supplement from Australia or some other country, and we found that Pseudomonas infection. Pseudomonas is so unusual for the children, but somehow that particular patient passed away because of the urinary infection 3 days after the surgery. So I have to be honest. I have to let you know that the one patient over the 500 patients passed away 3 days after the surgery.
Right.
So in that particular patient, Eishi, the one with Pseudomonas infection, probably the herbal supplement could have lowered her resistance. Herbal supplement may have lowered the immune system, but we can't be sure. So therefore, this is the data. I need to inform you.
Right. Well, that's great that that sort of data is available and that patients can ask about that. Is cost pretty consistent from provider to provider, or does that vary substantially?
It depends on the copay. Yeah, it depends on copay, but most of the patients insurance cover the pretty much whole cost.
Okay, got it. Okay.
And usually we can write a letter to the insurance to justify why is it that this center is capable to treat that type of intractable epilepsy.
Okay, great. So if a family chooses to pursue surgical evaluation, do you recommend beginning the process as soon as possible, or might there be value in, say, waiting until the summer so that you don't have to interfere with school, or is it better to avoid summer because that's the busiest time, or is the primary consideration getting surgery ASAP or surgical evaluation ASAP, or does scheduling and the family's other activities, does that play into it as well?
Mm-hmm. Yeah, in case patients have prolonged seizures, and including status epilepticus,
right,
or generalized convulsions, which may result in the breathing problem, then such patients may have increased risk of sudden unexpected death. In that case, it would be nicer to perform surgery as soon as possible.
Right.
But in case there is no such urgency, you can wait until summer, and then surgery can be done during the summer vacation, and the patient can recover fully by the beginning of the second semester, fall semester.
Right.
We are a busy program, but, we are willing to provide you the equal standard therapy regardless of the time. We are available summer, fall, winter, as well as spring.
Okay.
That's right.
And can the determination that someone is not a good surgical candidate typically be made after just the video EEG monitoring and MRI, or is there ever a chance or a significant chance that someone will go through the entire pre-surgical evaluation process only to find out at the end that they're not a candidate?
Usually by doing the video EEG, we will be able to determine whether the child is a good surgical candidate. And of course, we correlate the EEG with the MRI, the PET scan, as well as the clinical history and physical examination of the child. Unfortunately, probably around 20 to 30% deemed to be non-surgical patients. That means they are not candidate for resective surgery. However, we have also offered other treatment modalities, including placement of vagus nerve stimulation, as well as palliative surgery for those who are non-surgical, but we think these techniques or these procedures can lessen the amount of seizure and can improve the patient's quality of life.
Right. Okay.
And in addition, of course, we know about the ketogenic diet that we can also try on these non-surgical patients.
Absolutely. So if someone is determined to be a surgical candidate, how specific can you be in terms of providing individualized predictions? Like, can you tell a patient that they have a 70 to 75% chance of being seizure-free and a 4% chance of having complications and a 6% chance of having memory deficits? And can you get that specific, or and if not, what types of information can you provide to help families decide, on an individual basis whether they should have surgery?
Yeah, I mean, we can't be that specific. We cannot say 6% chance of having memory deficit, but what we can say is, in general, if patients have either hemispherectomy or temporal lobectomy, like up to 80 to 90% of chance of being seizure-free is expected. And for example, supposing that if the seizure focus is close to the language area or even involving the language area, we can say that if you remove the seizure focus and the language area altogether, risk of language deficit will be 6 times more than not removing the language cortex, something like that. But, even if patient has minor language deficit following the surgery, if child are younger than puberty, then, the chance of complete recovery is very good. So, if you do a early surgery, even if, you lose language transiently, the chance of recovery is high. So we can't give you the exact percentage. But in general, the language recovery is very good if surgery is done before the puberty.
Okay, and is that due largely to brain plasticity, or?
Correct, largely brain plasticity, because, adult brains already fixed. They talk, they speak, they understand using the left hemisphere exclusively. But the children can understand and speak using both left and right hemispheres. Even if left language area is damaged by surgery, right hemisphere will eventually pick up and will compensate. So therefore, they will have a very good language over the year after the surgery, if patient is younger than puberty.
Okay, great. And when you talked about percentage of seizure freedom rates, you mentioned the Engel Class 1 outcome, and that's free of seizures. Is that specifically free of seizures that impair consciousness or impair awareness?
Yeah. Anger class 1 means seizures, like freedom from disabling seizures. Freedom from disabling seizure means freedom from seizures associated with loss of consciousness or seizures associated with body twitching. So anger class 1 outcome includes patients who are free from such disabling seizures, but some of them may continue to have aura. Aura means, for example, like subjectively they may feel seizure is coming, but they don't lose consciousness, so therefore they can continue to drive the car. But anger class 1 includes such patients with aura, and the aura is okay.
Okay, so simple partial, or I guess the new term is focal aware seizures. Yeah, that those would be considered not disabling, and even though the law as written, says any type of seizure you're not allowed to drive for 6 months, most neurologists would counsel their patients that if you're exclusively having those focal aware or simple partial seizures, that it would be safe to drive.
Yeah, if the patient has partial seizures and they can feel that seizures coming, we have allowed them to drive, because theoretically we do not allow to drive if the seizures are associated with loss of consciousness.
Right. Okay. And then if someone has been evaluated for surgery and was found not to be a candidate, is it ever worth being reevaluated at a later date in hopes that the technological improvements will yield different results? Can you think of an example of that? And if so, how long would you wait? What would be a reasonable amount of time to wait to see to be reevaluated?
We can say after 2 years. Would you agree, Dr. Asano?
Especially 1 or 2 years. Yes, 1 or 2 years after the
previous evaluation, because especially if the parents are saying that there is a suggestion that the seizure is predominantly coming only from a certain focus, like if it is coming from the left or right, you will see more of the jerking more on one side. Then I think it is a good idea to reevaluate and revisit whether this patient can be a surgical candidate.
Mm-hmm. And another useful information is, if parents can videotape by the cell phone, that could be like seizures, like symptoms, may be useful information for us to localize or lateralize the seizure focus, because left side of the brain controls the right side of the body. Right side of the brain controls the left side of the body. So therefore, seizure coming from the left side often characterized by right-sided jerking and eye deviation to the right side, or even head turning to the right side. So if you happen to witness seizures, it would be nicer to capture the seizures by cell phone, assuming that patient is in the safe position. That kind of data could help us in the second evaluation.
Right. And is technology advancing fast enough that there is a possibility that the EEG will be, video EEG monitoring will be more sensitive, or the MRI will be higher powered, or something along those lines, where you'll see something that is there that wasn't there, or that you didn't find before because the technology wasn't sensitive enough? Or is that unreasonable to expect after just a few years?
Yeah, there are two ways of thinking. Like technological improvement is one way, but another way is, for example, young children tend to have bilateral seizure symptoms, like shaking in both and left and right side of the body. But over the age, over the development, patients tend to have one side dominant shaking, because of the brain plasticity changes. So rather than technical improvement, patient brain status, changing the patient's brain may give us the clue to localize where the seizure comes from. So, over the development, seizure type may be altered. So because of the brain status changes. So rather than technical advancement, developmental changes may be more important to localize the seizure focus, in my opinion.
Right.
So within 2 or 3 years, there might not be a breakthrough, but the patient brain changes may itself reveal the seizure focus in a better way. So re-evaluation 1 or 2 years later is not a bad idea. It's a good idea.
Great. And Dr. Luat, were you going to say something in response?
Yeah, I mean, I agree with Dr. Asano because, for example, the MRI was done only at the age of 1 year of age, and the brain is still developing, and lesion or resectable lesion may not be seen at that time. So it's a good idea to reevaluate with neuroimaging. Great,
that makes sense. Okay, before we open it up for discussion, did you have any closing thoughts or words of advice that you wanted to share?
Again, I would like to emphasize that, epilepsy surgery is a team procedure. You need to have a good neurologist and a good neurosurgeon. Children's Hospital of Michigan has outstanding neurosurgeon who is the Dr. Sandeep Sood, who can perform the hemispherectomy and top callosotomy through the borehole, like endoscopic surgery. So I hope that, many of the patients will benefit from his technique. Indeed, for example, some of the patients from Canada found out that, he does endoscopic hemispherectomy, and many of the out-of-state patients are now coming to Dr. Sandeep Sood because of the endoscopic approach. So I would like to let you know that there is an option to do a minimally invasive epilepsy surgery in state of Michigan.
Great. Okay, so let's...
And I also want to add,
yeah.
I'm sorry, can I add something?
Yeah.
Russ, just a quick thing. I just want to let our listeners to know that for any spells, whether seizure or not, that has not responded to any treatment for at least a year, warrants investigation and referral to a Level 4 epilepsy center.
Right. That's a key point, and we definitely try to stress that because unfortunately a lot of people stick with a general neurologist or even primary care physician for years and years and continue to not have good seizure control, and they've maybe tried 5, 10 or even more medications and have not been referred to a comprehensive epilepsy program. So that's a very important point, and you shouldn't delay seeking specialty care. So, all right, let's open it up for questions. Does anyone have any questions? And just as a reminder, too, if anyone has their lines muted, you can unmute the line either by unmuting your phone or dialing *6 if you used that to mute yourself.
Yeah, Russ, this is Dennis.
Okay.
And I was just wondering if the doctors could touch on the RNS system. Okay,
yeah, absolutely. Can you talk a little bit about the RNS, or responsive neurostimulation, or it's also known as the NeuroPace? Can you talk a little bit about that, and particularly whether it's it's used in general, but then also whether it has been used or may be used in the future in children?
Yeah, NeuroPace is again palliative surgery. designed for the patients who have seizure foci, particularly in the bilateral brain regions. So, but this therapy has not been approved in pediatric population. So therefore, has not been approved by FDA for the pediatric population. So therefore, in Children's Hospital of Michigan, we have not done that. So who could benefit from such RNS responsive neurotherapy, like NeuroPace? Particularly adult patients who have bilateral temporal lobe epilepsy may be the best candidate for the NeuroPace treatment. NeuroPace can automatically detect seizures and provide some forms of electrical stimulation each time. Then that therapy is expected to decrease the severity of seizures. It's unlikely that it's not feasible to expect that, given the patient will be completely free from seizures, but good reduction of seizure has been reported. So therefore, in the future, this RNS system could be option in children who suffered from encephalitis, because encephalitis often results in the bilateral seizure foci. In such case, RNS system may be a good option. But, in case seizure focus there is only one seizure focus, single seizure focus, and we can surgically remove it, then resective removal surgery, it should be much better option compared to NeuroPace RNS system.
Okay.
And some centers have also used NeuroPace if the seizure focus is coming close to the sensory motor cortex to avoid, if you resect the sensory motor cortex, it can cause side effect of weakness. So in some centers, they have used this if the seizure focus is located in that area.
Okay. Yeah, and Dennis, I should mention too, later in the year, we in May, we'll be having a specific conference call on the NeuroPace. So that'll be another opportunity to go a little more in depth on that topic. So.
All right. Thank you.
Yeah.
You're welcome.
Other questions?
This is Marissa. I was wondering, I got a question. You all had spoke about a herbal supplement. What herbal supplement were you talking about?
Yeah, herbal supplement which we have never heard was given to that particular patient. So, there was no label at all. So therefore, we don't know what was given to the patient. So therefore, we don't know herbal supplement was the cause of the infection. We still don't know because we were not sure what was given. So the parents show me tons of supplements, 20 or even more than 20, a cup of supplements. So, and then each of them were given to the patient in a random manner. So I really don't know how to evaluate the effect of herbal supplements. But Dr. Luat may be able to give you the information about, for example, medical marijuana or something like that.
Right. Well, medical marijuana is one of the type of treatment that we have been using for difficult to control seizures. But I want everyone to know that currently it is not yet FDA approved. But there are current research going on to facilitate its approval. It has been utilized in seizures related to Dravet syndrome and Lennox-Gastaut syndrome. And the medical marijuana with higher CBD oil component is the one that had been found to be effective in controlling these seizure types.
Right.
Okay,
So
thank you.
yeah, as far as complementary therapies for epilepsy, that's the cannabis or medical marijuana is really the one that has the most evidence thus far, and we're getting more and more evidence as these clinical trials are being completed. And we will have a full Learn and Share conference call on that later this year as well. But as far as other herbal supplements, there's really not a lot of data to support the effectiveness of any other herbal supplements. Doesn't mean that there's not possibly something out there that could be helpful, but as of now, there just simply isn't much evidence to support any kind of herbal supplement. Is that correct? Would you agree, Dr. Luat? Okay.
Yeah, I agree with you.
Agree with you, Russ.
Yeah. Okay, other questions? Any questions from any of the parents on the line?
Hi, I have a question. Okay, if the patient has already been through the PET scan, MRI, the EEG, and just has one more test to go through, but the seizure area has been pinpointed, does that necessarily mean that they will have to go through phase 2?
In case, PET, MRI, and the video EEG fail to find the seizure focus, it's one-stage surgery is not recommended. And second, can you give us a more detailed history, or what was recommended by your doctor? Can you give us more detailed history or findings of your child?
It was pinpointed to the left hemisphere. Right in that area. She's had the EEG, the PET scan, and the MRI, and I think the only last thing she has to do is the psych evaluation. And I was wondering, after going through all that and, kind of pinpointing the area, will she still have to go through phase 2?
Yeah, it sounds like unless seizure focus is pinpointed to the medial temporal region, it would be nicer to perform the phase 2 evaluation because, left hemisphere has language cortex. We want to know the exact margin between language cortex and seizure focus. So therefore, most of the institutions would recommend the phase 2 evaluations.
Okay, thank you.
How old is your child?
She's 6.
She's 6. And she's
right-handed. Then, right-handed or left-handed?
She's right-handed.
Right-handed. Then, 2-stage surgery would be recommended.
Okay. Thank you.
You're
welcome.
And how often does left-handedness or right-handedness accurately predict where the language focus is? Or which side is language dominant?
In case patient is left-handed and MRI shows massive structural lesion in the left hemisphere, those patients typically have language focus on the right side. So that means language has been already transferred to the right hemisphere. So handedness is quite useful measure to predict where the language area is.
Okay, great. Other questions?
Okay. Hi, Russ. It's Courtney. I had a question on the risks of the 2-stage surgery, and is there any risk of the brain mapping?
Risk associated brain mapping or risk following the brain mapping?
Like during the brain mapping and like the risks of the 2-stage surgery.
Okay. So there are 2 types of risk, 2 types of the brain mapping during the phase 2 evaluations. If you perform the electrical stimulation mapping, which is the currently gold standard, there will be a risk of stimulation-induced seizures. Because, the rationale of electrical stimulation mapping is stimulate portion of the brain and observe the response. If stimulation induces twitching of the left hand, then stimulated portion is considered to be a hand motor area. If stimulation impairs the language function transiently, then stimulation area is considered to be a language area. But sometimes stimulation may result in the seizure itself. So, but such seizure will be stopped by anti-epileptic drugs. So therefore, there is a risk of stimulation-inducing seizures, but the risk of permanent deficit associated with brain mapping is minimal. That's number one. Number two, there are new type of brain mapping we call four-dimensional brain mapping. Four-dimensional brain mapping is risk-free because what patients have to do is communication with a computer. So therefore, new type of brain mapping techniques does not have any risk.
Does that still require opening the skull, though, and placing
yes,
it on
yes.
the brain?
So that means, correct. So that means phase 2 evaluation include, so that means, phase 2 evaluations have some risk of infection.
Right.
As well as, as I told you, risk associated with epilepsy surgery procedures range more than 1%, but less than 10%. Because, placement of electrodes itself increase the chance of infections. But again, infection can be treated with antibiotics. And we also have a caution regarding the phase 2 evaluation. We do not place the electrodes 2 weeks. Some of the institutions, some of the major epilepsy center institutions may place the electrodes on the surface of the brain up to 2 weeks. But we don't do that because, that's kind of too long. So we typically perform the phase 2 evaluation up to 3 days. So therefore, the risk of infection is further minimized because of the shorter duration of the phase 2 evaluation.
Okay, thank you.
Other questions? Got about 5 minutes. Anyone else who hasn't asked a question, or anyone else who did ask a question but maybe has another question?
I think everything that I was going to ask, they answered. And while you were all talking, this was very educational.
Great. And has anyone?
Thank you very much.
Yeah, and thank you very much. Has anyone else on the call had epilepsy surgery before, and anyone want to share, or been partly through the process of being evaluated for surgery, and want to share anything about that?
Yeah, Russ, this is Greg.
Yeah.
I had surgery back in 2003.
Okay.
And it didn't work for me.
Yeah. What area of the brain was it done on?
On the back side. They wanted to put in a vagal nerve stimulator, but the doctor over at the hospital said that it wouldn't work.
Okay.
So you had brain surgery and vagus nerve stimulation too?
No, they just wanted to put in a stimulator, I guess.
So the reason why it didn't work is seizure focus is too close to the motor cortex. Do you have any idea?
I don't know why, but I got a doctor that he's thinking about trying it again. But if I should do it or not, I don't know.
Right.
Would you tell us?
Yeah, go ahead.
Would you please tell us the aura or like your seizure symptoms, then we may be able to give you some kind of suggestion. What kind of aura you have?
Yeah. My seizures are complex partial.
You don't have an aura, like a warning sign of seizures?
Yeah, I do have that. It's like spots in front of my eyes.
Oh, on the eye?
Yeah, I see spots in front of my eyes and then a blackout.
Oh, you see something?
Yeah, I see something.
Oh, I see. That means, okay, so that means that the seizure focus is still remaining in the back part of the brain. So, in case surgeon is confident, surgeon can offer additional surgery to remove the remaining seizure focus. That's one possibility.
And
they said before.
Go ahead.
But they said before if they'd operated, they found the problem area. It's on the right side. But they said if they'd operated, I'd have been a vegetable then. Because the memory on the right side is better than the left side.
I mean, but the memory is unlikely to be on the right side. So human tends to remember or memorize using the left hemisphere. So if the surgeon is confident that seizure is coming from the right side, memory may not be the two major concerns. So it might be nicer to discuss. It might be nicer to discuss with your doctor one more time.
Yeah, I'll be seeing him on the 17th again. I have to have an EEG on the 7th and a CAT scan too. I have to have on the 7th this month.
This month, okay, good.
Yeah, in general, aren't basically extratemporal surgeries have a much lower success rate than temporal lobe
That is correct.
surgery, and that includes like occipital or parietal lobes. That's relatively
less favorable.
Yeah, less favorable, exactly. So we should probably wrap it up. We're a little past 7:30 now. So I just want to thank everyone for participating, and of course thank Dr. Asano and Dr. Luat for sharing all this great information with us. And if anyone has any further questions after the fact, certainly feel free to reach out to me, and we'll do our best to answer those questions.
I would like to say Happy New Year to everyone.
All right. Thank you, Clint.
Happy New Year.
All right. And thanks, everyone, for participating.
Thank you.
Thank you.
Bye-bye.
Thank you, doctor.
Bye-bye.
Thank you, Russ, for doing this.
Yep.
Have a good night.
You too. Bye-bye.
Thank you.
Bye.
Good night.